So my name's Anna, I'm one of the Paediatric Oncology Pharmacists at the Leeds Trust, and I'm absolutely delighted to come here today and speak to you about the research that I did about 2 years ago. I looked at the information needs of parents on their child's oral chemotherapy. So just to give a brief background on what I'm going to discuss today, I'll just talk a bit about the background to the project, the aims and objectives, what methods I used to collect the data, and then I'll go into detail in the findings and discuss them. So over the past 10 years, there's been a big increase in the use of oral anti-cancer drugs. Of all the drugs used to treat cancer, it's assumed that about 25% are oral agents, and of the 400 new drugs in development, about a quarter of those are all planned as oral chemotherapy agents. So traditionally, chemotherapy has been given intravenously, and that's put a lot of the responsibility on nurses solely administering the chemotherapy in hospital. Whereas nowadays, with the focus shifting onto oral medicines, that responsibility has shifted to parents and caregivers, being responsible for managing the medicines at home, ensuring that patients are compliant, and also ensuring the safe handling of the medicines. So with this, there's a number of advantages and disadvantages. So with oral medicines, we can give them at home. It's convenient, it reduces hospital appointments, there's a decrease in travelling time, but also it brings about problems and challenges. So we need to make sure that parents understand how to give the medicines at home, and to support them in any difficulties that they face. In 2008, there was a national patient safety document that was brought out, and there was loads of information on the risks associated with oral anti-cancer agents. There have been 3 recent deaths and 400 patient safety reports of risks that had happened. This was alongside a number of NHS government documents that detailed how we at healthcare professionals should be delivering personalised patient care tailored to the needs of each individual. Without knowing what parents want to know, we can't tailor it to their needs. So this is where the project has come about. So it was designed to address the following question: are we meeting the information needs of parents regarding their child's oral chemotherapy? So I wanted to identify what the needs were, establish if we were meeting them, examine how parents prioritise these needs, and then analyse, compare and contrast the different ideas and opinions that were generated. So there's 2 types of way of collecting the data. There's quantitative, which is usually collecting data in numerical form that is analysed then mathematically. And then there's qualitative data, which sometimes people refer to as airy-fairy research. But actually, I find this qualitative data looks at people's subjective understandings, their feelings in relation to the context of their situation. And I thought that this would be more suited to this to answer my question. It would give me richer data, it would give me more of an understanding into what people feel. And I had looked at the literature, and there's only one other study in the UK that has looked at similar things. They had 3 outcomes, looking at information needs, awareness and knowledge, and safe handling. And they indicated that parents wanted to know more about the diagnosis or disease and more information on drugs, but that was as much detail as we got. So that's why I wanted to look at it in a qualitative sense. I wanted to explore it further. So how we included people. The child had to be between 0 and 16 because I was interviewing parents, and it's usually parents that take responsibility. They had to be on at least 1 oral chemotherapy agent, and they had to be treated at the hospital where I work. I excluded, due to cost because I couldn't afford a translator, parents that lacked English language skills, and also parents of children that had disease progression or that were palliative. So this slide is a little bit, but I'll work down through it. So I identified 52 children that were on oral chemotherapy. Of those, 6 were excluded because of English language skills or disease progression. And of the 46 that I could include, 42 had ALL, and there was 4 patients that had a brain tumour. Out of this, I purposely selected not specific families, because I was only actually new to the job at the time, but I purposely selected people at different stages of treatment. So people at new diagnosis that had been on treatment over a year, just to try and gather information from all different stages. So I sent out 44 invitations, and out of that, I had 26 replies. There was 8 no and 18 yes. And of the 18 yes, I actually only went on to interview 13 parents due to time constraints. So some of the reasons why people didn't want to take part were that some of the fathers said that their wife was taking part, or their partner. I wanted to interview mums and dads separately because their information needs can differ. One parent didn't want to be interviewed, and I suppose interview is probably a research term, but it wasn't me questioning the parent's knowledge. It was really me trying to find out in a discussion or a chat, are we as healthcare professionals providing you with the information that you need? It wasn't an assessment of knowledge, it was really just to find out overall how things were. So you can see how I got my sample sized. I used semi-structured interviews, as in I had a list of topics that I wanted to cover, but it wasn't the parent being questioned. It was a discussion about information, what types of information they needed, how we should supply it, what they classed as being important. These were recorded and then transcribed, and then I used a method called thematic analysis. So it basically is where you read through the transcripts, familiarise yourself with them, then you code the data. So if it was a feeling or something about medicines, it was coded, it was recoded, then the codes were grouped together and generated themes, and then I named my themes, but it'll become a bit clearer when I move on. So what did I find out? So 12 mums and 1 dad were interviewed. There was 1 couple that were interviewed together, so there was 12 children and 13 parents. This is just a summary of the participant characteristics. So there was quite a varied age range of parents from 20 up to about 50. Same with marital status. Majority were married, but there was some living with a partner, separated and single, and the same with educational status, so secondary school up to postgraduate. The children's characteristics, there was also a varied age range. There was 4 girls and 8 boys, and it's actually a little bit easier to see on this. So of the 12 children, 9 had ALL and 3 had a diagnosis of a brain tumour. And then of the 12 children, 2 were on 1 oral chemotherapy, 9 were on 2, and 1 was on 3. And then you can see, so this is what I hoped, was that I would get children from all stages of treatment, so the time that they were taking the oral chemotherapy. So you had patients here at the beginning of treatment, and then patients that were on oral chemotherapy over a year. So what did I find? There was 2 overarching themes that emerged from the interview or the data. There was the need for information. Parents needed information. They needed information to cope, to help them reduce uncertainty or establish control, and also to provide reassurance. They needed practical information on how to give the medicines at home, safe handling, and they also gave supportive advice for other parents. They needed treatment-related information with regard to how the drug works, what it is, and then this need for information varied. But on the other side, which I found it wasn't what I thought, I didn't know what I was going to find in my results, but there was also that underlying parental struggle, trying to maintain a normality while going through treatment. All the difficulties that parents faced with regard to the medicines given them at home. I'll go into them in more detail. There was an emotional journey of worry and self-doubt, thinking I'm not going to be able to do this. And then the balance of information, from being overloaded with information to needing more. So I'll go on to talk about that. So I've just split them up. So I'll talk about practical information and the difficulties with medicines. So problems with administration. So as you're probably aware, liquid formulations aren't always available, and at the time of this, we don't have a temozolomide liquid formulation in the trust. We didn't have a methotrexate, which we now have sourced, which is a help. So administration of liquids, and then again, sometimes the taste isn't also great. The people that develop them don't always think of the people at the end that are having to take them. But on the other side, so the difficulties that parents faced was also counterweight with how resourceful parents were. So there was one mum whose child wouldn't take the liquids, but actually he went from having a tube down and not being able to take the medicines to taking medicines to now taking tablets, so it's easy peasy for him. So you could see, and that was for a 4.5-year-old boy. So how parents they used actually like a game of practicing to swallow Smarties and Tic Tacs, which actually worked for that family, but every family is different. So side effects. One of the main ones was to do with the steroids. It's always something of a rough week or so, the steroid week, which I suppose I've given the information of that steroids can affect mood, but I didn't think of the significance of actually how that affects family life and other kids within the family. And there is a really good CCLG patient information leaflet dealing with behaviour in kids taking steroids, so that's something that I wasn't aware of at the time, and which is very helpful. One of the other contrasting experiences to do with side effects was to do with hair loss. Some people wanted anonymity and didn't want people staring and wanted it just to go away, whereas when the hair growth came back, people actually, neighbours and things, forgot and didn't realise that they were still going through treatment. So very different scenarios and patients still on treatment. So administration of medicines seemed to take priority. One mum said she was happy in the way I was given with what I had. I would have been more upset if I'd known what the chemo was doing to him and got home and didn't actually know how to give it. So it was the right way around. This was one thing that has come up, and the safe handling of chemotherapy. There was actually 4 parents that spoke up and said, well, actually we weren't aware of safe handling, we didn't know. And the only thing that they didn't tell us, which then we found out later, which I was very angry about, is that we had to wear gloves. We wasn't told that. And then on the other side, we had a parent who had been told about safe handling but actually chose to ignore it. I don't even wear rubber gloves anymore, I just give it. So you've got that contrasting. As pharmacists, how often do we have to revisit that? How often do we have to check up on parents? And not check up, but revisit the information and explain how important it is. So when I asked parents what would be the most important thing that you would tell another family, about the medicines, I was expecting something on the drug or dose, but actually this was one of the quotes that I found. Don't be scared of the word. The image that chemotherapy has, it's not just what you think about when you think of chemotherapy, which is sick children laying in bed with bald heads being sick. She is existing, she's going to nursery and she's functioning and she's having the chemotherapy, which is good for us. The parents' most important thing that came out was offering other parents reassurance. You can do it. Find a routine that fits in with your family. It's all about getting back to normality and maintaining that routine. So parents needed information to cope and also to maintain a normal routine. So even though most parents were happy, all parents actually were happy with the quantity of information they were given, they still did a little bit of research outside of that, more so for reassurance. So this lady, her friend, had done some research just to agree with what she'd been told. Parents wanted information to reduce uncertainty, so as in, sometimes we don't have the answers. This lady wanted to know what was going to happen, because that was the first thing I said, is he going to die? And everyone was like, well, we don't know about that, but the consultant was really blunt and said, we don't know. He might do, he might not, and I like that. Parents want us to be open and honest, which we are, and they don't want things sugar-coated, but sometimes we don't have the answers. Most of the information was to establish control. You want to know what was happening, get the information in time, so to plan and so to fit things around. That was about receiving the 12-week cycle plan in maintenance for ALL. So treatment-related information. So information on indication and how the drug works and what the drug does. So we got told that she needed to take them as part of her treatment, but not really what they did or any in-depth information. Nothing specific, nothing specific to a drug. This lady actually had to go away and research her own, which actually made me feel, I felt disappointed that we had failed, that we actually hadn't directed them to a proper website or given them the information at the time that they needed. So we'll go on to show the developments that we've done. So side effects of treatment. Some people were split. Some people wanted to know all the side effects because they wanted to know what to look out for. Other people didn't want to know any side effects because they just didn't want to know. They felt that they would worry about them. And some people wanted to know the side effects but worried about them constantly and thought they were going to get everything. So it was very mixture. The emotional journey was really sometimes to do with lack of understanding of what was happening, and worry about managing the oral chemotherapy medicines at home. And this lady said, I never thought in a million years I'd be able to do what we've had to do, and I've learned a lot in these couple of years. And another mum said, at the beginning there's all this terminology, but actually now for me it's rolling off her tongue. And she was quite impressed that she'd got to grips. As we said, kind of what's come out is that the need for information varied, which as a healthcare professional then that's difficult because from person to person, what they want to know and when they want to know it differs. So at the time they were satisfied, but it still felt like a bit of information overload. But when they got home and started administering things, then they felt that they needed to know. They didn't really know as much as they wanted to ease their mind. You're just bombarded with information, diagnosis information, appointments from all of us, and it's very difficult to probably find that balance. Some people wanted bullet pointed information to summarise down a list of do's and don'ts. Other people wanted information to be given to them in written form, so they would have it at home and then they could reference it again. I think 2 out of the 13 patients wanted to be directed to websites. Mainly it was written information backed up by verbal information. So this is what has come out. What we found is really that it's like a spirally pig's tail, and it's about information needs, so it's just constantly changing. So you've got an information need here and it's met, and then time might go on and another information need. And this can be from diagnosis to treatment all the way through. So changing. So what have we done in practice? Within the multidisciplinary team, we're trying to define clear lines of responsibility of who gives what information. So as that we're not duplicating and bombarding or overloading everybody. We want to have clear documentation of the information provided. We've developed some patient information leaflets, and we've got dosing information charts and things to do, our top tips of do's and don'ts. But what has been really, really helpful is the parent input. So through this, we've done some parent or patient information leaflets. But from speaking to parents, they've helped me word things so to make it clearer. So for example, previous information has said, with regard to mercaptopurine, give 1 hour after the evening meal. And there was one child who had an extracurricular activity, and they were being taken out of that to be given it exactly 1 hour, where actually there is a bit of flexibility. So we've reworded it, which seems like a small thing, but we say now at least 1 hour. So there is flexibility. There is other things to do with how it's given, and they've helped me with regard to food and milk for mercaptopurine. We've also got a dose and information chart, which many parents find helpful, and they tick off the days as a reminder, especially if it's a child that's going from one household to another, so it's clearly documented who's given it or ticked off. So limits to the study. Well, 13 parents were deemed large enough for this study, but it probably wasn't large enough sample size to gather all the themes that would come out, so you couldn't say that the data was saturated. There was over-representation of mums, which was some of the mums wanted to be interviewed and said they would do it in preference of the dads, but it might have been nice to actually get some more dads and have a more balanced view of it. There was also probably over-representation of parents that took an interest in their child's treatment. So those, because they freely gave up their time to come and be interviewed or discuss it. And possibly for the parents that were at the end of treatment, they may have recalled things different. So there's like what we call a potential for recall bias. I would like to look at fathers' information needs in the future, and if I can ever get some funding to look at parents and caregivers that lack English language skills. And then actually maybe look at all the medicines, not just the oral chemotherapy. So this research wasn't done just to get me my master's, it was done to inform practice and improve practice. So we've tried to improve things within the Leeds Children's Hospital. We've presented the information at the Paediatric Oncology Pharmacist group in November, and also at the National Paediatric Pharmacist group at this information day today, but I'm hoping also to get it published in a journal to get to the wider view, because that's the whole idea of doing research, is to push things forward and make improvements. So I just want to say a big thank you and a heartfelt and sincere thank you to those parents that gave up their time freely when appointments are a lot and hospital time, and they shared their experiences. Everything here has been anonymised, all the names have been changed, and this study just wouldn't have been. I feel as a pharmacist I have learned absolutely loads from these parents, probably more so than in that frame of time than I have over the last few years, so just a big thank you to them.